That was a great introduction. Thanks a million. Yeah, I'm Dr. Caoimhe Hartley. And so my background is general practice. I did my training here in Ireland, and then I moved to Canada. I lived in Alberta for 5 years, and I did some extra training there with regards to menopause and hormones. I worked in a fertility clinic and a dedicated women's health clinic while I was there. And I moved home just before the pandemic, and I've since opened up a women's health with a clinic with a sort of skew towards menopause called Menopause Health, which is in Dalkey, County Dublin. So just a little bit of background when it comes to menopause itself. So I just think it's interesting to kind of know how, like, where our attitude toward menopause was kind of rooted and where it came from. So traditionally, going back, if you go back far enough, menopause was really seen as a kind of a sign of hysteria, and women were actually at one point sent away to go and sort themselves out in a sanitarium. And you can see there about even the origin of the word uterus actually comes from the word hysteria. So I think that gives you a sense of kind of where we are in terms of our attitude towards women's health through the ages. But thankfully, we've moved on. So what is menopause? So menopause itself is actually just the terminology that we give to our final period, our final menstrual period. But what that really reflects is that our ovaries are no longer producing some hormones that we would have had in abundance for the kind of preceding however many years through our reproductive lives, and that we are not ovulating anymore. And because of that cessation of producing these hormones, our body goes through some adaptive processes. We start to adapt to this new hormonal environment. And as we do that, we get symptoms, and it can have long-term implications for our health as well. I'm stuck. There we go. So when is menopause? So the average age of menopause, certainly in the Western world, is somewhere between 50 and 51. However, you can be younger. So about 1% of the population under the age of 40 and about 5% of the population under the age of 45 have their periods stop. But this can happen for loads of different reasons. So it can be spontaneous, just which is often genetic, that it just happens naturally for no other cause other than genetic predisposition. Some medical interventions like surgery, having your ovaries removed, perhaps as a preventative measure if you're someone who carries a high risk genetic predisposition to ovarian cancer or the BRCA gene. Even following other pelvic surgeries like hysterectomy or a treatment for heavy bleeding, which is called an endometrial ablation, and certain types of chemotherapy can all take their toll on our ovaries. And you can have menopause for that reason too. So what are the symptoms and signs? So I know this has kind of been spoken about, but just to kind of cover that a bit again, the most obvious one is a change in your menstrual cycle. So this is often something that happens early, although in saying that, it's actually quite common to see some perimenopausal symptoms. So things like PMS type symptoms and mood changes and even hot flushes can happen before your periods actually start to change. So it can be a bit of a difficult diagnosis to make from my perspective at times, and it can be hard to help someone tease out, you know, are my symptoms due to environmental stresses and factors, and are they due to COVID, like in the background stress that we all carry or certainly carried throughout the last year because of that, or is it because of hormonal change? And the problem is that blood tests often don't clear the picture up at all, because the underlying issue is that your hormones are actually bouncing around a lot and they're fluctuating, and so they can be really hard to measure accurately. I suppose the other classic symptom that people know about is what we call vasomotor symptoms. So these are hot flushes and night sweats. And not everybody gets them, but about 75 or 80% of women will. And unfortunately, about 15 or 20% of women will actually have hot flushes that last for the rest of their life. But for the majority, these are symptoms that actually improve with time. Your body sort of adapts and the hot flushes go away. The average length of time, not to freak you out, but the average length of time to have hot flushes and night sweats for is about 7 or 8 years. So it's a lot longer than I think people sort of realize. The physiology of hot flushes is quite interesting. So essentially, there's part of your brain called your hypothalamus, and that acts as your thermoregulatory center. It's a bit like a thermostat in your brain. And it has a range for most of your life. It, doesn't mind being sort of up here and it doesn't mind being down here, and it'll correct your body temperature if you go outside of that range. And as you go through menopause, and we don't actually really understand why this happens, there's probably other hormonal factors at play, not just estrogen. But as those fluctuations in your hormones happen, that thermoregulatory range narrows. And all of a sudden, your body's really not happy. Well, your hypothalamus in your brain is really not happy with you going above this little line here when it used to tolerate your core body temperature being up here. So small little changes in your core body temperature, all of a sudden your brain starts to react to that, and it's trying to cool you down. But it does that by making all the blood vessels, whoosh open and rush to the surface and make you sweat. And so you get this flushed feeling usually, and then it can be followed by a feeling of being really cold and actually freezing, because it has actually managed to drop your core body temperature, and now you're inappropriately, and now you're freezing. So that hence the kind of covers on, covers off, covers on, covers off all night long. Other symptoms that are really common, cognitive issues are actually really common. Some people call this brain fog. It's a bit different for everybody. Some people it's more memory, for others it's more focus and concentration. Verbal fluency is one of the things I'd hear about a huge amount. So that, word on the tip of my tongue, or I can't think of someone's name, or I can't think of a certain word, that becomes really common. And it's not it is in your head, and it's like literally in your head, but it's not in your head. So they've actually studied this quite a bit, and there's really interesting studies in the States showing that you can do brain scans. So you can put someone through a PET scanner or a scan where you can see blood flow through their brain, and you can actually relate reduced blood flow in certain parts of your brain to someone's estradiol level, independent of age. So you take a younger woman in her early 30s who would generally not have symptoms like this, and you remove her ovaries and you make her menopausal and you put her through a brain scanner, she will have blood flow in a similar pattern to a woman in her 50s who has a similar estrogen level to her. So they've kind of categorically shown that something is definitely happening in our brains when we go through menopause. Joint aches and pains, low energy, poor sleep, I'm sure that resonates with lots of people. And then what we call genitourinary symptoms of menopause. So these are the bladder issues, having to pee frequently, worsening incontinence, sometimes stress incontinence. That's the classic, I can't cough or sneeze or get on a trampoline. I'm laughing because we've recently bought a trampoline and I'm dreading it. So that, lack of confidence on a trampoline, and vaginal dryness, really common as well. Low libido is hugely common. And I don't think, again, I'm not sure people really appreciate how common low libido. And the three main hormones produced by your ovaries are estrogen, progesterone, and testosterone. In brief, estrogen, really important, almost too much to cover today because it has so many important functions, but that's probably the principal hormone that we're talking about when it comes to menopause. Progesterone is actually the pregnancy hormone. It's the hormone you release when you've ovulated to help to kind of turn the lining of your womb, your endometrium, into a slightly more hospitable type of lining to an implanting embryo if you become pregnant. And then testosterone, equally important, actually only recently being more understood, the important actions of testosterone. So it's getting more attention, which is good. So they're little messenger molecules. And as I say, like a key in a lock, they produce an effect in a target tissue. And sometimes they produce different effects in different target tissues. Bit of a complicated slide, but essentially just a quick overview of kind of a normal menstrual cycle. But the take-home message basically is, in the first 2 weeks, in a typical, and obviously not everybody has a 28-day cycle, but if we take a sort of average lady having a 28-day cycle, first 2 weeks, her ovaries are recruiting lots of follicles, and each of them is growing a little egg, and she's trying to mature, her ovaries are trying to mature one of those eggs inside these follicles to be dominant, and that's the follicle and egg that then ovulate. And that happens usually around day 14, give or take. Those follicles release a load of estrogen. So the first 2 weeks of your cycle, day 1 is the day you get your period. And from that point on, you start pumping out more and more estrogen. And then the second 2 weeks of your cycle, you ovulate. Your estrogen levels do a sort of bump. So they dip and then they go back up again, and then they fall just before you get your period. You release a load of progesterone. Like I said, that's the hormone you release when you've ovulated to try and turn that lining in your womb into something more effective if an embryo implants, and then that falls and you get a period. But this goes haywire, unfortunately, with perimenopause. So ovaries, they produce your eggs, there are many different types of estrogen, but throughout your reproductive life, when you're not pregnant, your ovaries are your main source of estrogen. Your adrenal glands, they sit on top of your kidneys on either side, they produce other hormones too, and they actually convert some hormones into estrogen too. So estrogen, as I say, has an action sort of on, pick a spot everywhere. So as I said, little follicles, they produce estrogen. This cycle of growing these follicles, ovulating, etc., it's actually controlled by hormones from your brain, and this constant conversation happening between your ovaries and your brain. So your brain is sort of constantly testing the water. It's looking and seeing, how much estrogen do I have? Have I ovulated? What else how much stress am I under? And it can actually sense all of that. It's a clever little spot. And it will release hormones almost like I suppose like the accelerator and brakes on your car, and it is controlling what your ovaries are doing. So the other, I think, important thing to know about estrogen is that it stimulates growth of the lining of your womb. So that's what happens in those first 2 weeks. That lining is getting thicker and thicker under the influence of more and more estrogen. And that becomes really important in someone who's perimenopausal, as we'll see in a sec. I won't go through all the other stuff because it's a bit wordy. So different types of estrogen, as I say, and different types of estrogen are produced at different times in our life. Affects head to toe, as I say, so brain, heart, ovary, vaginal tissue, breast tissue, obviously, and bone, again, which becomes really important when we're talking about the loss of this hormone through menopause. I'm sort of stuck in the mud about talking about estrogen in the brain because I do think it's really important, and it's something we're gradually learning more and more about, which is great. We think it's a really protective hormone for our brain, so it's important to help our brain speak to other parts of our brain, so neurotransmitters. It's a hormone that's actually really neuroprotective, so it's good at helping us repair damaged parts of our brain or damaged neurons. Some of the studies in the States would have shown, I don't know why they're all in the States, but they've done a lot of neuroscience studies in America and looking at this particular thing. And they showed women who were premenopausal, so normal estradiol levels, when they did verbal fluency test, they almost always scored higher than men. So they sort of consistently outperformed men. And as they went through menopause, their scores dipped. So it's kind of U-shaped, because as they came through post-menopause, their verbal fluency actually improved, and that's with no intervention. I find that really helpful to me because I think it can be a really distressing symptom to be like, I can't find the word and my memory is gone and I have this foggy brain. Knowing that it's likely to be transient without any intervention can be really helpful. The impact of estrogen on how quickly you get from A to B in recovering is really controversial. We've unanswered questions. How much estrogen should you be on? When should you start it? Does it matter what other hormones we prescribe along beside it? So they're all unanswered questions. But just to know, look, if I do nothing, if I exercise and look after myself, my brain fog is likely to improve with time is really important. One thing I loved in the study was they showed that at their lowest point during this curve, they just came down to the male verbal fluency level and then they got better. So you're just coming down to a male level when you're losing your brain function through menopause. So exercise is the one intervention that they showed to be really important and really helpful. So I think that's worth kind of taking note of. Okay, so perimenopause. So perimenopause is brutal in a way for lots of reasons. And one is that it's a real roller coaster. So it comes and goes. It can make you feel like, really symptomatic 1 minute and then think, for the next couple of months or cycles after that, maybe I was just imagining it. And then you become symptomatic again. So it sort of comes and goes for a lot of women. But essentially what's happening, if you go back to the whole point of going through the physiology, as your ovaries are trying to recruit those follicles at the beginning of the month, as we age, there's fewer follicles available to us. And so our estrogen levels drop a little at the beginning of the month. And our brain, in constant conversation, so our brain picks up on that and thinks, oh no, we're not producing as many follicles. And so we have this evolutionary safety net built in to kind of squeeze the last drop, if you like, out of our reproductive life. And we do this by our brain releasing a hormone called FSH, or literally follicle stimulating hormone. And it's basically screaming at your ovaries, work harder. And they do, and especially in early perimenopause, they're great. So they start to produce more follicles. In fact, they often produce too many. And so early perimenopause is characterized by having times of sort of little dips in estrogen and then way too much. And so you have this excess of estrogen. And estrogen, as I had mentioned, actually stimulates the lining of the womb. And one of the reasons that we see really heavy bleeding through perimenopause is because you get these kind of peaks and little spikes of high estrogen. Gives you really bad PMS type symptoms like tender breasts and headaches and mood symptoms, because you're having big swings of hormones now, whereas previously you were in a much more settled range. But also it drives a lot of bleeding. So it's one of the reasons we see a lot of bleeding. There's other reasons too, but that's one of them. So as I say, bit of a roller coaster. So what happens when we get to menopause? And our ovaries, no matter how much our brain is sort of, pressing on the accelerator, there's just nothing, no response from our ovaries, because we eventually reach a point where we just don't have any follicles that are good quality enough. And so we stop producing estrogen altogether. So that's menopause, your periods stop. You go that full year, that full 12 months with no period, and you are postmenopausal. But the impact of losing that estrogen is actually felt throughout your body. So you get changes in the walls of your blood vessels that can lead to the buildup of plaque. It leads to hardening of your blood vessels very, very gradually over 10 years or more. But that can have a knock-on effect of developing blood pressure, cholesterol. We think that actually this protein plaque that you can build up in your brain, which is one of the reasons that we see Alzheimer's, actually probably happens in perimenopause, even before you run out of estrogen. Osteoporosis, so developing a really dramatic loss of bone density, which can lead to fracture and chronic pain and different things. You lose your bone density at a rate of about 2% per year, and that starts really from the time of your final period onwards for about 5 years, and then it sort of plateaus a bit. Vaginal tissue is something that really doesn't get talked about half as much as it should, because it can be really debilitating. So your vaginal tissue loves estrogen and never really gets over the loss of it. So it never really adapts. It sort of mourns it for the rest of your days. And one of the issues is that you lose about a third of your collagen as well when you lose estrogen. And collagen is what keeps a lot of our tissue plump and stretchy, and it gives it elasticity and give. And there's, you get reduced lubrication, you get a change in the pH of the vaginal environment. So you get different bacteria living there, which often lead to increased urinary infections. That change in collagen coincides with a change in the tone or the kind of give in your pelvic floor. So it's quite common to start to get a bit of prolapse, especially if you've had some pregnancies. And that can actually change your anatomy in that region. And so it can change the anatomy of where your urethra and bladder sit. And that can also increase urinary symptoms and infections. If you do a vaginal exam on someone who's premenopausal, when you look inside at the vaginal canal, you actually see lots of little folds, like they're called rugae. And they're what give you stretch. And in someone who is postmenopausal and you look in, it's often shiny and flat. So the wall has become thinner. And the introitus on the outside, the opening to the vagina, same idea. It gets thinner. It's much quicker to tear and bleed. It actually kind of tightens and shrinks a little bit. So it can make sex really uncomfortable as well. So what are your options to do anything about all of these nasty things that I've mentioned? So you've loads and loads of options. So we've, traditionally old HRT would have been by mouth usually. So it would have been a tablet form of estrogen. An old type of estrogen called Premarin would be the brand name. So which literally comes from pregnant mares' urine. So that's where they extracted estrogen from the urine of pregnant mares. And that's what would have been used in the WHI, that really big famous study that happened in the 90s. We've moved on, thankfully. So now we have some dermal preparations. So we now give estrogen as much as possible through your skin. So a gel, a patch, and a spray are the most common routes through your skin. And there's big advantages to that, which we'll cover in a sec. You can still get some tablet form of estrogen, but we actually have a more modern type of estrogen in the tablet now. So you're not stuck with that old-fashioned type of estrogen. And don't forget, there's loads of vaginal options. There's a cream, there's a pessary, there's vaginal tablets that are inserted to treat locally, just treat the vaginal symptoms. So HRT, hormone replacement therapy. If you are someone who still has a womb, if you haven't had a hysterectomy, you need 2 hormones. So you need estrogen to give you all the benefits, to make you feel better, to give you some of the health benefits for bone and heart. You need a second hormone, progesterone, because estrogen can stimulate that lining of your womb. It will get thicker, you can get bleeding, you can get abnormal cells. So we give that second hormone to try and keep the lining of your womb protected. So progesterone goes in there and it sort of like calms everything down, keeps the lining nice and thin and inactive. The lowest risk way of taking your HRT is probably to take estrogen through your skin. Tablet form of estrogen is metabolized by your liver, so it can bump up your clotting risk. Your liver is responsible for making clotting proteins. And when we take estrogen by mouth, we see your liver making more of those proteins, and your risk of stroke and blood clot go up. We don't see any of that with dermal estrogen. Even if you've had a blood clot, you're safe to take dermal estrogen. Good rule of thumb is to aim for the lowest dose that you need to get on top of your symptoms. Body identical hormones is kind of a buzzword that you might see in a lot of the forums and a lot of, if you Google HRT now, and all that means is that basically a lot of the modern type of estrogen we use now its chemical structure is identical. It's a replica of the type of estrogen. If you go back to those 3 different estrogens our body produce, it's a replica of the type of estrogen that your ovaries would have been producing in abundance prior to becoming menopausal. I get asked a lot about, is there an age at which I have to stop my HRT, or is there a duration where I have to stop my hormone therapy? And the short answer is no. So there's kind of a global consensus now that actually it's not sensible to be telling people to stop HRT at a particular age or after a particular length of time. You take it for as long as your benefit outweighs your risk. That's nuanced. And obviously it's usually in consultation with your GP or a specialist or whoever it is. So what are the benefits? Obviously symptomatic benefits. You should improve, you should feel better. That's the hope. But the 2 main benefits are for your bone and for your heart, particularly bone. So it's really effective at reducing bone density loss. And considering 50% of women over the age of 60 or 65 are going to develop osteoporosis, that's actually, it's really important. And we actually think a lot of losing independence and mobility and chronic pain and obviously fractures, they're all things that can happen with osteoporosis. So really important that we're looking after our bones. And estrogen is really good at that. The coronary heart disease cardiovascular benefit isn't as dramatic. I find it's been overstated a little. If you look at the studies, like statistically looking at this, there is coronary benefit, definitely, but it's small. Like if you're someone who smokes and you decide to give up smoking, that will have a much bigger impact on your long-term risk of cardiovascular disease than taking estrogen. But it's a nice sort of, I won't say side effect, but it's a nice sort of byproduct of going on hormone therapy to improve your symptoms, to know that, well, if I'm under 60 and if I'm within 10 years of my last period, you're in a category, you're within a window of opportunity, you're in a category of women who are going to potentially see some reduction in their risk of cardiovascular disease. It kind of slows down that development of cardiovascular disease. So just briefly to kind of put numbers on it, in case I haven't sort of drilled it home enough, but dermal estrogen is the way to go. So we see less stroke, less heart disease, and less venous thromboembolism, which is blood clots in your leg or your lung. Dermal estrogen actually has less effect because other things that your liver produces, so other proteins, and if you take dermal estrogen, we see less of an effect on these other proteins that I've listed there at the bottom. They are proteins that go around and mop up things like thyroid hormone or testosterone. So you might find in women who are really sensitive, their thyroid levels actually drop a little bit, their testosterone levels drop, and that can translate to a reduction of energy or libido. So dermal estrogen is better. Okay, what about breast cancer? So again, something I spend a huge amount of my day talking about, and it's really complex, unfortunately, because no one thing causes breast cancer. It's usually a combination of maybe having a genetic predisposition or environmental factors like smoking and how much exercise you do and your diet and how many pregnancies you've had and what age you were having your first pregnancy and so on. So there's all these factors that feed into breast cancer. And there's different types of breast cancer. There's hormone dependent breast cancer. There's ductal cancer. There's, breast cancer that isn't being driven by hormones. So there's loads of different types. So it's not all the same. And when we're talking about the risk of HRT in breast cancer, that's the other problem, is that there's loads of different types of hormone therapy. So it's very difficult to give people a nice sort of, succinct, like, this is your risk of breast cancer with HRT. It's so dependent on lots of different things. The take home message really is that the breast cancer risk is low with modern HRT, that it's not dose dependent. So it doesn't matter what dose you are on. What matters is your own background risk, how long you're on HRT for. So it's duration dependent. The longer you're on it, the more of an impact hormone therapy has on your risk, and the type of hormones you're on. Estrogen only HRT, if you've had a hysterectomy, you don't have a womb, you're just on estrogen, your risk of breast cancer is probably not significantly increased for the first decade, depending on what study you're reading. If you're using both hormones because you still have your womb, well, your risk probably is increased, but the risk is probably similar to lots of lifestyle choices we make, like drinking 1.5 bottles of wine a week will increase your risk after 5 years in a similar way to HRT. Even a high fat diet, it probably carries the same excess risk as HRT. So you get the idea. In terms of mammogram screening, no need to have a screening mammogram before you start HRT unless you are due one because of your age. So women over 50, every 2 years, we should be screening with mammograms through breast check. I won't go through the physiology of progesterone because it's a bit much to cover here, but it's important for protecting the womb. Body identical progesterone. There's all these different types of progestin. The one that we use most commonly is called micronized progesterone or body identical progesterone, or the brand name is Uterigestin. You can take it by mouth. You can insert it vaginally if you prefer, and there's other kind of benefits of doing that. And essentially, if you're still having bleeding and you're perimenopausal, you take your progesterone for 2 weeks a month. If you've gone a full year with no bleed and you were postmenopausal, you take a lower dose, but all the time. The women on the sequential who are taking it 2 weeks a month, they will probably still have some regular bleeding. If you're taking it all of the time, we don't expect you to have any further bleeding. The body identical Uterigestin is considered to have slightly less of an impact on breast cancer and breast density. And it has some other effects. So that particular progesterone may have a small effect on anxiety and improved sleep. That's my dog, by the way. Other option, Biomarina coil. That's another really common option. I love it for the convenience. And if you're in perimenopause and you're having really horrible bleeding, or it's heavy or difficult to control, the coil is a great way of a convenient way of sort of protecting you from that, or controlling that. And obviously it's contraception as well, which is great. Just briefly, because I guess I get asked all the time about testosterone. We actually have a ton of testosterone ourselves. We make about 3 times more testosterone than we do anything else. But we convert that testosterone sometimes into things like estrogen. It's definitely important for libido and sexual satisfaction. It may be important for energy and mood and brain fog. We don't know yet. We're waiting on more data and more research about that. It's U-shaped. So you start with a certain amount of testosterone, it peaks in your mid-30s, it falls. And there was a recent study showing that in your 70s, it starts to pick up again. So you can tell your 70-year-old sexual partners to watch out as it starts to go on the incline over the age of 70. So yeah, it may have benefit and fatigue, but we're kind of waiting on more information. Hard to get in Ireland, but there are a few different preparations. We sometimes use the male preparations, but in really small, about 1/10 the dose of what we'd give to men. It's through your skin, it's a gel. You need blood tests to monitor your testosterone level, which is really important and gets missed a lot. And we've good safety data for about 2 or 3 years of using testosterone. After that, we're not so sure. So it takes a bit of guidance. So in a nutshell, remember your screening, mammogram, cervix, cervical screening, STI screening if you have a new sexual partner, bone density screening. There are non-hormonal alternatives that, again, it's just too much to cover here today, but there are really good medications. They have some side effects. They don't carry any risk of any hormonal dependent cancer. And they're very effective at hot flushes in particular. Don't forget lifestyle, really important. So limit all those triggers like alcohol and caffeine. Yoga and cognitive behavioral therapy have some evidence to them. Exercise, really important for your bones and really important for your heart. Vitamin D for your bone health every day, which is a supplement from your pharmacy over the counter. Calcium in your diet. And that is it. Sorry, I probably went on a bit long. I got carried away talking about my hormones there.
No, that was great, Dr. Hartley. Thanks a million. If you want to stop sharing your screen,
Yes.
I have 2 questions, and there was actually more, so I might just send them on to you, and if you get the time to answer them. But that was great, and I definitely picked up an awful lot of tips there myself, and I'm sure everybody else did here that's in attendance. So just one question was it was from a lady who just going to get up there now. So she had gynae surgery a few years ago, and she had an ovary and a fallopian tube removed. So can this affect menopause, and if so, in what way? Now I think you touched on that there a little bit. Yeah.
Yeah, so she has another ovary, and generally what happens for the majority of women is that other ovary, the remaining ovary, will compensate. So it shouldn't really have any impact, but it more than likely slightly increases her risk of having earlier menopause. Maybe not dramatically, it depends on what age she was having her surgery. But yeah, there have been studies looking at pelvic surgery potentially having an impact on producing a slightly earlier menopause.
Yeah, okay, great, thank you. And just another question was that if you think you are, perimenopausal, or you're in full swing of the menopause, how do you know? Like, is it detected, by a blood test, or how do you know, like, how are you ever 100% sure?
Perimenopause is really tricky. So if you go to measure an FSH level, which is the hormone that we use to measure menopause, and so what we're looking for, if someone has, if a 30-year-old came into me and said, my periods have stopped and I haven't had a period in 6 months and I don't know why, and we've no other explanation, she's not pregnant, and so you're trying to work out, well, is it menopause? You'll measure an FSH level. And if she has 2 FSH levels 6 weeks or more apart, above 30, that's representing her brain producing this kind of stimulating hormone in response to her ovaries not functioning anymore. And so that confirms menopause. The problem is, if you try to do that in someone in their late 40s who's still having periods, but they're erratic, and you're trying to pin down this raised FSH level, it's coming and going. So their FSH level goes up, their ovaries start to produce estrogen again, their FSH level goes down, and it goes like this. And so it's a moving target, and it's a really difficult thing to diagnose with bloods. The guidelines, the NICE guidelines in the UK would be that if you're under 45, it's a good idea to do blood work, kind of as a, not a shot in the dark, but to see, can we establish why someone under 45 might be having symptoms like that? But we don't hang our hat on them. And if you're over 45 and you are having irregular periods and menopausal symptoms, you're perimenopausal. So if your periods have started to become more than a week irregular, so if you're usually a 28-day cycle, and then the next month you have a 21-day cycle, and the next month you have a 21-day cycle, and then you have a 28-day cycle. If there's 7 days or more difference in your cycle from month to month, and it's new, that's probably perimenopause, especially if it's accompanied by cyclical changes. My mood dips for a week. My mood dips, I get breast tenderness, I don't feel great, and it's getting more pronounced that week to 2 weeks before my period, and it comes and goes. So yeah, it's a really difficult thing to kind of pin down. You need a sort of an investigative mind on you to kind of, and we often do bloods to rule out other things like thyroid hormone and make sure everything else is as it should be, that we're not barking up the wrong tree.
Yeah. No, that's great. Yeah, thank you so much for again taking the time out.